let's move on a little bit from the cellular therapies to other agents of interest. Isatuximab is a monoclonal antibody. You've been heavily engaged with that, Tom. Tell us about that.
Well, Isatuximab is an anti-CD38 monoclonal antibody, and like daratumumab, it does show single-agent activity upwards of 30%. Also, like daratumumab, it shows increased efficacy when combined with an IMiD and dexamethasone. That was just published in Blood, showing in lenalidomide refractory patients response rates in the order of 50+%. At the current time, Isatuximab, and we'll see some data at ASCO, it's being combined with pomalidomide and dexamethasone. It looks to be a very active combination. The response rates were 60 to 70% in relapse and refractory patients. And they've launched a phase 3 trial of Isatuximab, pomalidomide, and dexamethasone versus pomalidomide and dexamethasone. And I think that is the avenue for Isatuximab to get hopefully FDA approved in sometime in the next 2 to 3 years.
Bendamustine, anybody using? There is an abstract at the meeting talking about bendamustine with pomalidomide. Anybody using much bendamustine?
No.
No, didn't think so. More of a European sort of flavor to that drug. All our lymphoma colleagues seem to like it. Why are we not so enthused? We just have other better alternatives. Do you think that's the...
We use melphalan. It's the same thing.
Okay. What about other drugs that are coming? Let's spend a few minutes on those. What's got you excited that's on the horizon, Gareth?
So I'm most excited about the bispecific antibodies than the CAR-Ts, really. I kind of think that that's really our challenge over the next years, to find sort of groups of patients where these are really indicated. And to be honest, for properly well-defined high-risk disease using GP70 or P53 biallelic inactivation, those are really a significant challenge. And so I think those agents and that group of patients is really going to benefit from these drugs.
Small molecule drugs, Venetoclax, anybody got experience with that? And Saad, what do you... Tom, I know you've used it too, so...
So I think Venetoclax is probably the most exciting small molecule we have right now.
Why is that? So
absolutely. It's an oral BCL2 antagonist, and it has a single-agent activity, specifically in the translocation 11-14 patients, of about 40%, which is quite impressive, and probably leads the way of developing a predictive biomarker-driven therapy in myeloma, which would be the first. So I think that's exciting, and then with bortezomib combination, the overall response rate reaches north of 80% in the 1 to 3 prior lines of treatment patients. Even in bortezomib refractory patients, there appears to be activity.
90%, as I recall,
Yeah, I believe you're right.
Tom, I know because I talked you into this last year. You've been using some Venetoclax, so
You did talk us into it last year.
Tell me about it.
Well, we've had trouble with the daratumumab refractory patients. Those patients in our hands have already received carfilzomib, have already seen daratumumab, and we needed another agent, so we started them on Venetoclax and bortezomib. And we did it in both the patients that had 11-14 translocation and those that did not have 11-14 translocation. In fact, we've had good responses in both groups. It's certainly been better in the 11-14 translocation, but we've seen response rates in the order of 20 to 30% in truly, penta-refractory patients, which is I think pretty dramatic at this current time.
So I think I think it's remarkable, but I think it's the start of precision medicine for myeloma. It's the drug par excellence, which will allow us to segment myeloma into different subgroups. Yes. And once Venetoclax is approved, and we're doing it, we'll fall in line and have a way forward for bringing in lots more drugs to the myeloma space.
We might. The one caveat I would say to that is, MCL1 inhibitors may actually treat both.
Yeah, absolutely.
And so if you have an active MCL1 inhibitor, and that's a target we're certainly very excited about, and there are a number of ones, it may supplement Venetoclax.
But not in trials, you're just starting trials.
Yes.
Not yet, just starting trials right now.
My own experience with Venetoclax was very positive. Even as a single agent, I've had some very nice and deep and long remissions in my patients. I'm actually pretty keen on that one.
Patients tolerate it really well.
Yeah.
Also.
Yeah.
And it's approved for CLL, so it's actually out there in the market if you work with your insurance company. So Ivan, your centre's been working with Selinexor. I know you've had some decent experiences with that agent. Tell us a little bit about that.
Yeah, so I can tell you experience from my patients that I put on the study. It is an agent that now is in 5th-line pentarefractory patients and clearly has seen very dramatic responses. The patients that I've had have also been complicated by extreme nausea, to the point that for the first time in my experience, I've had patients actually beg for me to come off study, despite the fact that they've been having such a good response. Now, and these were about 3 or 4 patients for whom standard antiemetics were not even coming close to treating them. My understanding is that this is possibly improved with subsequent patients that I've gone on. I don't know if I just had put...
Yeah, I don't think that's been a universal experience. So in the trial that has been reported recently, the overall response rate was about 20%, 21% to be precise. And I think there was a high incidence of nausea, but with appropriate management, apparently many patients were able to stay on the drug. Any experience over this side of the table?
Yeah, I mean, I think nausea certainly can be an issue, but with sort of aggressive pre-medication ahead of time, you can mitigate that. What really struck me was the data both in terms of bortezomib and carfilzomib refractory patients. When you combine it with selinexor, the response rates were really good, and the GI tox dropped significantly, almost in half. And so it's almost like the best antiemetic for selinexor is a proteasome inhibitor.
Wasn't there a difference in dosing of selinexor as well when combined with the PIs?
Not at the outset. There was subsequently you could reduce the dose.
Because my experience was with single agent selinexor, and that may be an important
the dex certainly makes it better.
So we'll watch that space. I think it's a drug that's still in clinical trials. Let's